Sayla sat on the thin exam table under the humming fluorescent lights, palms cool against the vinyl. She had rehearsed this visit in her head for weeks. The exact phrasing of symptoms, the dates she would cite, the questions she would ask if the conversation started to narrow into quick explanations. The clinic smelled of rubbing alcohol and lemon cleaner, and to Sayla, felt faintly like every room where she had once been told to calm down. This time she carried a small ledger folded in her bag, a lined notebook with the label she had written that afternoon, symptoms and dates. It was not drama she wanted, it was precision. She had learned that when systems prefer shorthand, the remedy is to make the long version inconvenient to ignore. She planned to ask for names, timestamps, and copies of notes. She planned to record nights she could not sleep, the medicines that dulled and then failed, the specific days she missed work because walking hurt. Her resolve was quiet and methodical. In that notebook, each entry would be a stitch, and the stitches together would be a map that a clinician, an advocate, or a specialist could follow. She breathed and walked into the appointment carrying that careful intention. The doctor arrived and listened in the practiced way of someone trained to move through lists. A polite nod, a quick scan of prior notes, fingers flipping pages. He offered a familiar phrase, "It's probably stress," he said, and wrote a short line that felt like shorthand dismissal. There was no cruelty in his voice. The moment was procedural. Still, the effect landed the same. Sayla felt the old tightening in her chest, the quiet echo of being smoothed into an explanation instead of being examined. She had been told she was anxious before, told that pain could be emotional, told to take rest and return if things did not improve. Those lines had history. Sayla decided she would not allow a single sentence to replace months of experience. That evening, she opened the little notebook and began to write. She labeled the first page symptoms and dates and entered neat lines. The nights the pain woke her, descriptions of sensation, the weather that seemed to make it worse, what she had eaten before certain flare-ups, the exact hour she had to sit down at work because standing became impossible. She photocopied past lab results, underlined numbers that had trended upward, and stapled medication lists in chronological order. The ledger felt like a small armor. It translated bodily experience into readable, shareable material. Writing did not feel like complaining. It felt like assembling a case so the next clinician could not explain her away with a single sentence. Sayla treated the work like evidence gathering. She requested a full copy of her chart and learned how to ask for timestamps on clinical notes. When the front desk responded with vague delays and clerical excuses, she asked politely for the responsible staff member's name and an exact callback time, and then followed up. She called the clinic's patient advocate and left concise messages. Please document functional impairment. Please include time-stamped entries. The words were clinical because they had to be. Her aim was to create a record that could be read plainly and could be pointed to when shorthand threatened to erase the pattern. Her friend Rosa, who worked in medical research, became her quiet ally. Rosa helped Sayla read blood panels and pointed out markers that, though technically in reference range, had moved in a way that mattered. You can't let one quick sentence override a trend, Rosa said. Collect it, date it, make it undeniable. Sayla printed timelines, taped lab reports to pages, and labeled each packet with the specific issue she wanted addressed. At the next appointment, she presented a packet instead of an apology. The packet contained dated entries, a one-page summary of how the symptoms limited daily tasks, and a short list of direct questions. She opened with a single line. Please document that chronic pain limits my ability to stand for more than 10 minutes. Saying it felt like putting on a small, practical armor. The phrasing steered the conversation toward facts that could be written down instead of assumptions that could be shrugged away. This is quieter resistance than most cinematic arcs. There was no viral confrontation, no dramatic moment captured on a phone. The work was tedious, phone calls, follow-ups, requests for notes, careful tracking. But it created something harder to ignore than a single complaint. A ledger of experience that could be read by clinicians, advocates, and, if necessary, officials. Sayla's decision to document was a demand that medicine do what it promises, to attend, investigate, and respond to the person in front of it. That night she closed the folder, placed it beside the small plant she had kept since college, and felt a steadying resolve. The path forward would be slow and exacting, but it would be precise. She was no longer merely asking to be believed, she was making it impossible not to see. If this hooked you, hit like, leave a comment about a time you were dismissed by a professional, and subscribe to follow Sayla's story.
Seela woke with the notebook open on her kitchen table and a list of tasks going over in her head like a script. Request the full chart, ask for time-stamped notes, and find a clinician who would document functional limits. The ledger felt less like a journal and more like a plan. She photocopied lab reports, printed a one-page summary of symptoms, and labeled each packet with dates. At the clinic, the front desk was polite and slow. "Records take time to process," the attendant said, and Seela noted the name badge and the exact phrasing. The delay could be clerical, she reminded herself, but paired with the doctor's quick shorthand, it looked like an erasure. She called the patient advocate and explained in clipped clinical terms what she needed, an addendum that spelled out how pain limited standing and walking. The advocate, Diane, listened and then taught her how to request one. Learning the language of medicine became a small tactical project. Seela stopped saying, "I hurt," and instead recorded measurable details. Unable to stand for more than 10 minutes without significant pain, or require seated breaks twice during an 8-hour shift. Those phrases, when spoken in a consultation, became lines that could be written into charts and shown to insurers. Medicine responds to specifics, and Seela made specificity her tool. Insurance hurdles followed. A referral to a specialist was returned as not medically necessary. Another request was marked insufficient documentation. The denials were formal and impersonal, but Seela treated them as data points. She filed each denial into a folder, called the reviewer's office for a recorded explanation, and transcribed the response. At times, she felt exhausted by the bureaucracy. At other moments, she felt oddly empowered. Each paper was evidence that could be assembled into a clear case. An online patient group offered pragmatic support. Members shared templates for appeal letters and scripts to prompt clinicians to document functional impairment. Seela adapted those templates and printed copies to bring to appointments. The group stories mirrored hers, small dismissals piling into suffering, and their shared language felt like a toolkit. When she saw a different clinician, a rheumatology nurse practitioner named Dr. Patel, she presented the packet and spoke plainly. "Please document that I cannot stand for more than 10 minutes without pain." Dr. Patel read the materials and asked targeted follow-ups. For the first time in months, a clinician paused on specifics rather than reverting to the "it's stress" script. Dr. Patel ordered targeted tests and noted functional limitations in the chart. Even then, obstacles persisted. The insurer demanded repeated documentation before authorizing certain treatments. Seela drafted an appeal letter, citing chart excerpts and attaching a brief note from her supervisor describing missed shifts. The appeal was slow and legalistic, but she treated it as evidence work. Every line, date, and signature mattered. Emotionally, the process was uneven. Some days the ledger felt like a wound reopened. Other moments, making tea, watering a plant, were small repairs. She learned to channel frustration into updates, logging a new flare day, calling a clinic admin, posting in the support group. These acts built momentum. Small changes followed. A receptionist who had once given a scripted apology now answered by name and confirmed callback times. A technician texted to confirm an appointment. Neighbors in the online group asked for copies of her appeal templates. Sela discovered the ledger's usefulness extended beyond her case. It was a replicable method that others could use. Work remained. Tests would take weeks. Appeals could be denied. But Sela had shifted the frame. This was not about being believed. It was about producing a record medicine and insurance could read. Where shorthand had once dismissed her, specificity began to insist on attention.
The next months felt like an exercise in microscopic patience. Sela scheduled appointments with methodical care: primary care, rheumatology, occupational therapy. Each visit an opportunity to translate experience into documentation. Her notebook grew heavier. Lab printouts, notes from nurses, a supervisor's letter describing missed shifts. Every page was a hedge against casual dismissal. On one afternoon, a technician misfiled a set of blood results. When Sela noticed, she asked for a time-stamped correction and for the name of the person who entered the record. The clerk apologized and made the change. It seemed small, but Sela had learned that small clerical errors, left alone, become scaffolding for misunderstanding. She began to request metadata routinely: who recorded a result, when it was entered, and which code accompanied the entry. Those details altered how reviewers and administrators read her file. Her relationship with providers evolved unevenly. Some clinicians bristled at the extra time required to document function. Others adapted. Dr. Patel became a cautious ally. Instead of writing shorthand like probable anxiety, she began recording explicit lines. Patient reports inability to stand more than 10 minutes. Conservative therapies tried without benefit. The chart that once read as a dismissal now contained sentences that could be quoted in appeals. Language mattered. It shifted the burden from a single shrugged phrase to a traceable record. Bureaucracy pushed back in predictable ways. An independent medical reviewer denied a request for an advanced scan, citing insufficient objective findings. Sela recognized the phrase as a gatekeeper's brush-off. In response, she assembled more documentation: a physical therapist's assessment showing decreased endurance, a supervisor's note detailing missed work, and a timeline of flare-ups tied to specific workplace incidents. She wrote concise cover letters for appeals that framed the evidence plainly and left little room for vague dismissal. Community resources proved vital. An online patient forum recommended a patient advocate at a regional hospital who specialized in complex cases. The advocate, Simone, reviewed Sela's packets and suggested 2 strategic moves: request an independent functional capacity evaluation and get any employer accommodations in writing. Those recommendations created an auditable trail that could not be shrugged away in a single review. Workplace accommodations became leverage. Sela presented a short memo to her supervisor outlining restrictions and proposing temporary measures: seated tasks, staggered breaks, and a trial period with adjusted duties. Her employer formalized an accommodation plan with dates and signatures. That documentation was powerful. Insurers and reviewers could now see tangible effects on attendance and performance that corroborated Sela's medical records. Emotionally, the strain arrived in waves. There were evenings when she wondered if endless paperwork had become the center of her life. Other times she felt steady and purposeful. Progress often came in small increments: a nurse who confirmed receipt of documents, a phone call scheduling a functional assessment. Those moments felt like pivot points, the process moving from platitude to measurement. The functional capacity evaluation was exhaustive. Examiners timed standing tolerance, measured gait, and recorded endurance during standardized tasks. The results aligned with Sela's reported limitations. The evaluation produced objective data that translated lived experience into metrics recognized by insurance reviewers. It did not invalidate her pain. It rephrased it in the language systems required. Armed with the evaluation, Sela escalated the appeal. An attorney she consulted helped draft a concise appeal letter citing chart excerpts, the functional assessment, and workplace documentation. They included a one-page timeline of incidents and requested expedited review. The legal language was careful but clear. The packet presented a pattern of functional impairment supported by objective measures and corroborated employer statements. As appeals moved through channels, Sila tried to keep balance in ordinary life. She visited a friend's art opening, took a slow walk by the river, and tended the small plant on her windowsill. Writing short gratitude notes between log entries helped her remember she was more than a file. Those moments did not erase the work, but they kept her whole. Procedural victories did not cure the underlying condition. Pain still flared, and days remained difficult. But the documentation shifted the conversation. Where a single offhand clinical note once closed doors, meticulous records made it harder for systems to rely on shorthand. Sila's insistence on specificity forced medicine and insurance to engage with evidence rather than assumptions, and that change altered the course of her case.
A review conference was scheduled with the insurer's medical director, a gray-suited man whose calendar could reorder treatments. Sila arrived with the package she had refined over months: the functional assessment, time-stamped chart excerpts, her supervisor's signed accommodation plan, and a concise cover letter translating lived pain into the insurer's language of medical necessity. The meeting felt oddly formal. The director scanned the evaluation as if hunting for a single checkbox. Sila spoke in measured sentences, pointing to the evaluation's numbers: standing tolerance, decreased gait endurance, flare patterns tied to work tasks, and to the supervisor's note confirming missed shifts. She framed each point to leave little room for shorthand dismissal. When the director asked about prior conservative measures, Sila produced dated therapy notes and medication trials, each annotated with outcomes and dates. The specifics pushed the conversation toward facts rather than impressions. A week later, the denial arrived. Insufficient objective findings. The phrasing was familiar, a procedural barrier that could be rebutted only by further documentation. Sila responded methodically. She requested a full rationale, the criteria applied, and the reviewer's identity. Simone, the patient advocate, filed an immediate appeal and organized a parallel peer review request. The patient forum rallied. Members sent template letters, a physician in the group offered a supporting affidavit, and her supervisor expanded his earlier note to quantify workplace impact in concrete terms. Sila engaged a lawyer who specialized in insurance appeals. His first strategic move was to demand an independent peer review by a specialist in the relevant field. The external reviewer, a respected rheumatologist, examined the packet and wrote a careful note emphasizing the functional capacity evaluation and the documented lack of improvement after conservative therapy. Her conclusion urged the insurer to authorize targeted imaging and specialist consultations to clarify the underlying issue. Pressure mounted. The insurer's posture softened under the authority of the peer review and the weight of organized advocacy. They authorized a limited set of tests and a short trial of specialist-guided therapy. To Sila, this felt less like a concession and more like the system answering to documented persistence, a door cracked open by consistent evidence and collective insistence. The tests revealed inflammatory markers that suggested a clearer diagnostic path. A specialist proposed a treatment trial that, if effective, might reduce pain and restore function. The authorization allowed for a sequence of clinical steps: imaging, targeted medication, and monitored therapy that translated ledger entries into actionable medicine. Each approved step was a procedural win, converting private history into public, reimbursable care. Emotionally, the process was mercurial. Appeals, calls, and legal maneuvers carved into her days. There were evenings when fatigue pooled like rain. Yet every small victory, an authorized test, a supportive peer note, a supervisor's corroboration, felt like a stitch in a slowly mending garment. The ledger on her kitchen table had become more than record-keeping. It was an auditable narrative clinicians and reviewers could read. Community support continued to matter. Simone accompanied her to appointments, patient forum members checked in with templates and encouragement, and her employer honored interim accommodations. Those allies reduced isolation and transformed private suffering into organized action. As tests were scheduled and appointments stacked, Sila found small rituals to steady her: a short walk by the river, a phone call with Rosa that turned paperwork into laughter, and the evening ritual of watering the plant by the window. The work ahead required patience, clinical trials, follow-ups, and careful recording of treatment response. But for the first time in months, Sila felt the path forward was navigable. The ledger had started to do its quiet work, to make visible what systems had preferred not to see. It had turned private pain into bureaucratic evidence, and evidence changes what officials can ignore. She slept less easily that night, but with a different kind of focus. Not the anxious knot of being disbelieved, but a steady procedural attention to appointments, to forms, to responses. The next week's promised tests, a treatment trial, and more documentation. This felt, finally, like clinical progress. Not a dramatic cure, but a methodical approach that could produce measurable improvement. Sila closed the folder, set it on the counter, and whispered a small thanks to the ledger that had held her witness.
The treatment trial began with a small ceremony of practicality: a pharmacy pickup, a treatment schedule taped to Sila's fridge, and a folded sheet of side effect warnings in her bag. She logged doses in the ledger, scored pain each morning, and noted sleep and nausea. The work was banal but necessary. Small entries that turned private sensation into auditable data. Early progress arrived in fragments. Some mornings she could stand an extra minute or two. She celebrated these increments with small acknowledgments: a longer shower, coffee enjoyed standing. The plant on her windowsill unfurled a new leaf, and she took it as a quiet ally. Those tiny wins mattered because they turned abstract hope into metrics she could point to in a letter or an appeal. Setbacks came with the same ordinary stubbornness as progress. A dose brought nausea. A week passed with no measurable improvement. The insurer demanded objective response before approving continued coverage. Sila pushed back with updated logs, a therapist's note, and a supervisor's written confirmation of missed shifts. The ledger's neat columns were suddenly the grammar the system required. Each entry, date, pain score, activity limit, became a sentence in a case she was assembling. Community support remained crucial. Rosa drove her to an appointment when transit felt overwhelming. Members of an online forum traded practical tips for managing side effects and shared appeal lever templates. Her supervisor formalized accommodations, providing signed dates that bolstered her claims. These acts made invisible burdens visible and eased the isolation chronic illness often creates. A diagnostic pivot offered a breakthrough: a targeted injection to isolate an inflamed joint. The procedure required authorization and a copay that tightened Sila's budget, but she agreed. For 2 days afterward, she moved with uncommon ease. Standing in a store line without calculating the next moment's pain felt startlingly ordinary. Those 2 pain-free days were small but powerful. Objective, temporal improvement that could be cited in appeals and clinical notes. Not every test proved decisive. Some imaging returned ambiguous findings that specialists debated in careful, hedged terms. Medicine lived, Sila discovered, in probabilities more than certainties. Her ledger adapted to nuance. Instead of binary claims, it recorded trends, degrees, and hours of relief. The narrative she built was less a single arc and more a mosaic of evidence. The insurer's review panel responded to the accumulating documentation. After receiving the injection report, functional assessment, and employer notes, they granted an extension of medication coverage and approved follow-up imaging. The decision did not cure her, but it bought critical time. Time for trials to run, treatments to take effect, and more data to accumulate. That extension felt like a narrow bridge across an uncertain river. Emotionally, the trial was mercurial.
There were days of gratitude, texts from friends, the warmth of Rose's company, and nights when the ledger felt like a heavy burden of obligations. Sela developed rituals that helped. A 10-minute playlist stretch each morning, a weekly call that mixed paperwork with gossip, small moments that kept her whole. She found humor in small things, too. The plant required less paperwork than the clinic and kept growing anyway. Gradually, the ledger's public life expanded. Patient forum members used her templates. A clinician asked permission to share her one-page summary as an anonymized example of clear documentation. The notebook that had started as a private defense became a modest teaching tool. It translated subjective suffering into a form institutions could read, and that translation mattered. Where a single offhand clinical note had once closed doors, carefully assembled evidence made it harder for systems to ignore systematic patterns. By the end of the trial's first cycle, Sela could point to measurable improvements even as limitations persisted. The road ahead remained long, filled with follow-ups and small bureaucratic fights. But she felt steadier, not because pain had vanished, but because the ledger and the allies who read it had created a route through the indifferent machinery of care. The work of living with chronic pain, she realized, was less about a singular cure and more about making institutions answerable to lived experience.
Months folded into a rhythm that was both procedural and fragile. The ledger stayed on Sela's kitchen table, updated after visits, phone calls, and each small shift in pain scores, an impartial chronicle of endurance that could be parsed into evidence. She learned the cadence of administrative systems, when reviews were scheduled, which forms required double signatures, and the exact phrases insurers used to defer decisions. As clinical data accumulated, Sela moved from individual appeals to collective action. Simone introduced her to a regional patients coalition that advocated for clearer documentation standards and insurer transparency. The coalition collected case studies, anonymized packets that paired functional assessments with timelines of denial to present to a state review board. Sela agreed to share parts of her folder. The trade felt risky but purposeful. Her packet became one example among many, a pattern that suggested the problem was not isolated. The coalition's work brought new meetings, regulator interviews, strategy sessions, and community briefings. Regulators requested redacted charts. Insurers supplied counter-arguments. Specialists wrote clarifying notes. The process was slow and technical, but it created leverage. A draft guidance began to emerge, urging insurers to consider formal functional assessments when evaluating claims and to document denial rationales with greater specificity. Locally, change took quieter forms. A clinic administrator who attended a briefing invited the coalition to redesign intake forms so they captured functional limits rather than vague phrases. Simple edits, checkboxes for standing tolerance, prompts for precise work limitations, and required timestamps on notes felt suddenly strategic. Sela realized systemic change could be embedded in paperwork as much as argued in hearings. Fatigue remained real. Being a case study brought exposure, public presentations, interviews, and repeated retellings of painful episodes. Friends admired her tenacity, but sometimes retreated from the constant administrative grind. Sela guarded private rituals, slow walks by the river, a radio show, and evening tea to remind herself she was more than a list of symptoms. Practical victories accumulated. The regulator opened a focused inquiry and recommended pilot programs for expedited reviews when objective functional measures met defined thresholds. That recommendation created new leverage. Insurers now had to justify denials with clearer, documented criteria when a formal functional assessment existed. It was bureaucratic language, but with teeth. Her employer converted temporary accommodations into a formal, signed workplace plan with scheduled reassessments. That documentation became durable evidence for appeals and regulatory reviews. A manager change would no longer erase the accommodations. The stability mattered.
When the insurer reviewed the packet again, employer corroboration tipped a balance that had previously favored administrative doubt. Sela helped the coalition run a workshop at the community center: how to request time-stamped chart notes, how to ask clinicians to document functional limits, and how to draft concise appeal letters. People arrived with denial letters and lab printouts and left with checklists and templates. The ledger idea, writing dates, scoring pain, and collecting employer notes, spread like a practical habit. The workshop felt like a small civic moment, private records becoming public tools. Clinically, results were incremental. Some treatments reduced flare frequency, others needed adjustment. The goal shifted from cure to management, maximizing usable function and minimizing disruption. The insurer's earlier authorization for targeted imaging and a treatment trial had proved consequential. Measurable improvements in standing tolerance accumulated into data that could be cited in follow-ups. In private life, she kept small anchors: watering the plant, cooking a simple meal, and writing a single gratitude line in the ledger steadied her. Those acts were not distractions, they were reasons to keep insisting the system answer. The ledger remained a modest instrument, part record, part teaching tool, part civic technology. Change, Sela learned, accrues in checkboxes and signed memos as much as in headlines. It required stubborn documentation, allies who could translate personal testimony into policy terms, and the willingness to make private struggle legible to institutions. The fight continued, patient and procedural, but it now included other hands. The ledger on her counter no longer felt like a solitary burden. It had become a small civic map others could use.
When the regulator published its recommendations, Sela sat at her kitchen table with cold tea and a cautious sense of relief. The guidance was careful and bureaucratic. When a validated functional capacity evaluation accompanies clinical records, insurers should offer expedited review and document precise reasons for any denial. It was not a sweeping reform, but it created a practical lever. Months of ledger entries, the dated logs, the supervisor's notes, the functional assessment had nudged a system to pay attention. The coalition celebrated with a small briefing at the community center. Neighbors, clinicians, advocates, and a few reporters filled folding chairs. Simone outlined next steps: distribute documentation templates to clinics, pilot expedited insurer reviews, and fund a legal reserve for strategic test cases. People who had once navigated denials in isolation now shared a common playbook. The energy in the room felt less like victory and more like disciplined optimism, the kind that sustains long work. Back at the clinic, changes appeared in small but material ways. Intake forms included prompts for standing tolerance and checkboxes for functional limits. Nurses confirmed timestamps would be routine. Some clinicians still defaulted to old shorthand, but when Sela requested explicit entries, staff complied without resistance. These minor adjustments multiplied. Legible records allowed clearer appeals and reduced openings for vague, dismissive denials. An insurer agreed to join the pilot under regulatory scrutiny. Sela met with their liaison and offered feedback on appeal templates. Seated across from claims officers, she felt the oddness of negotiating procedure with an institution that had once denied her care. It was, she realized, the ledger's civic work. Private details translated into administrative requirements that shaped others' decisions. Early pilot metrics were modestly hopeful. Cases that included formal functional assessments had higher authorization rates for targeted diagnostics and interventions. Denials that remained were accompanied by longer, more specific explanations rather than perfunctory phrases. Clinicians reported fewer wasted visits spent convincing reviewers of basic limitations. Data rarely feels dramatic, it accumulates. These shifts made it harder for shorthand to substitute for assessment. Pushback arrived in predictable forms. Industry groups warned about administrative burdens and potential costs. Op-eds debated efficiency versus oversight. The coalition responded with data showing improved diagnostic yield and fewer redundant appointments. The debate moved from internal memos to public fora, widening the conversation and the political stakes. For Seela, the fight had graduated from clinical files to policy conversation, less intimate but more durable. At home, life rebalanced around small pleasures. Seela walked in a neighborhood park and noticed ordinary details, the tremble of birch leaves, a neighbor's dog insisting on greetings. She still updated the ledger, but the notebook no longer occupied her every waking hour. It had become a tool she used, not the story that used her. One clinic administrator sent a brief note thanking Seela for participating in training. A clinician credited the pilot with improving intake practices. Those small acknowledgments mattered because they signaled systemic uptake. Months of stubborn documentation had seeded practical change: forms, training, a pilot program, and an emerging public resource. The coalition published a short handbook, templates, clinician language samples, and an insurer checklist for expedited review. Seela's anonymized packet appeared as a model. The guide circulated to community centers and clinics and was downloaded widely. Private documentation had become public knowledge, a reproducible method for others who faced similar dismissals. There were no dramatic finales. Instead came the steady accrual of infrastructure: better forms, clearer reviewer criteria, a small legal fund for test cases, and a community literate in documentation. The ledger's quiet work had multiplied. Seela's notebook taught others to translate pain into policy. She watered the plant on her sill, added a single line to the ledger: guidance published, pilot ongoing, and felt that small sentence both recorded and instructed. It was, in its modesty, a practical kind of continuity. The months after the pilot felt like the quiet labor of maintenance rather than the drama of breakthroughs. Procedures that had once been optional, time-stamped notes, explicit prompts for functional limits, routine collection of employer corroboration, had become habitual in some clinics and stubborn exceptions in others. Seela learned that systems shift unevenly. Some offices integrated the new intake form overnight, while others required repeated reminders from advocates. The ledger on her kitchen table remained a steady instrument. It no longer created the entire story, but it kept the facts close at hand. She watched how small acts multiplied. A nurse in a neighboring clinic emailed to say she had updated her intake script after the coalition's workshop. A medical resident requested Seela's anonymized one-page summary as a teaching example. Those gestures felt like quiet confirmations that the work had ripple effects. At the same time, the administrative grind continued: periodic denials, staffing changes, and the occasional clinician who preferred old shorthand. Change, Seela understood, was not a single event, but a pattern of practice repeated over time. The coalition matured into something less improvisational. They secured modest funding for a legal reserve and began training volunteer advocates who could triage appeals and help patients compile packets. Simone coordinated community clinics where patients could get guided help producing functional assessments and employer letters. The handbook the coalition published circulated to community centers and patient groups. Downloads turned into shared practice and new volunteers. Seela's role shifted. She was no longer only a litigant, but a teacher and a steward of the method she had fashioned. She led workshops on documentation, walked new advocates through sample packets, and helped clinicians rephrase notes so they could survive administrative scrutiny. Those sessions often felt tender. People shared the small humiliations that had led them to collect evidence, and Seela guided them toward practices that made institutions answerable. Personal life threaded through this civic labor. She continued working in a job that required adapting duties, and she made space for small pleasures: a weekend pottery class, a slow dinner with friends, the ritual of watering the plant whose leaves had unfurled over seasons. The ledger stayed on the counter, updated, but no longer the only thing that defined her days. Instead, it had become one tool among many, useful, necessary, but not exhaustive of who she was. There were setbacks. A clinic rotated staff, and a new intake coordinator reverted to the old shorthand. The coalition had to send a gentle reminder and offer a brief retraining. An insurer experimented with a new review rubric that initially looked promising, but then introduced new semantics that required coalition attention. Each setback required the same patient response she had learned to give: document the lapse, notify allies, and push for correction. The rhythm of repair became familiar. It was civic practice rather than spectacle. At a neighborhood event marking a modest anniversary of the pilot, people praised the practical handbook and the training sessions. A young mother told Seela she had used the checklist to get her own employer to formalize accommodations. Harold, now semi-retired from his ledger duties, sent a note: "Keep the dates. Keep the room." Those small messages mattered more than headlines. They were proof that the ledger's method had entered everyday practice. Seela thought often about the ethics of visibility. Making private pain legible had helped many, but it also meant exposure. Not everyone could or should become a public case. The coalition's materials included sections on privacy, on anonymizing packets, and on who to trust with sensitive records. The handbook emphasized consent and guarded sharing. Civic tools require civic care. On an ordinary morning, she watered the plant, checked the shared drive for new uploads, and sent an email offering a clinic a short training slot. The plant's leaves caught the light, and for a moment the city felt like a place where small practices could change the shape of care. The ledger remained, lines of dates and symptoms and workplace notes. But its most important work had begun to be done by others who no longer had to invent a method from scratch. This was not the end of struggle. Prejudice and bureaucratic fatigue persisted. But Seela had learned the civic craft of translating experience into durable evidence, of building modest institutions that could hold systems accountable. She kept tending the ledger because it taught others how to notice, to record, and to insist. The apartment, the plant, and the notebook, they were part of a wider argument that institutions should be designed so people are seen, not smoothed into shorthand.
Seela's story does not end with a single headline or a dramatic courtroom scene. It closes with a set of practical habits and a civic infrastructure that others can replicate. Time-stamped notes, formal functional assessments, employer corroboration, and trained community advocates who can translate private suffering into public procedure. Those habits do the steady work that laws and headlines rarely accomplish. They make systems answerable in routine ways. If you face a similar dismissal, the steps are concrete and immediate. Document with dates and simple details. Ask clinicians to record functional limits explicitly in your chart. Secure written workplace accommodations, and seek allies, patient advocates, clinicians, community organizers, who can help transform isolation into organized evidence. The ledger is a humble tool. Dates, symptoms, signatures. It is not glamorous, but it is hard to ignore. Change remains slow because institutions are built for inertia. But patient documentation paired with communal insistence nudges those systems. Intake forms are rewritten, reviewer criteria become clearer, and insurers must produce specific rationales rather than perfunctory denials. Seela's persistence shows that private endurance can accumulate into public capacity when people teach one another to notice, to record, and to demand accountability. There is a cost to visibility. Disclosure must be handled with consent and care.
The Coalition's handbook stresses privacy, anonymization, and boundaries, tools to protect those who cannot or should not become public cases. Civic tactics must be ethical as well as effective. If this story resonated, do something small now. Start a dated log. Ask your clinician to write one concrete sentence about functional limits, or share this episode with someone who needs it. The work is humble, repetitive, and practical, and it matters. Subscribe for more equal voices, real people, procedural lessons, and the slow, often unseen work of making institutions answerable.